Somewhere between 70 and 80 million Americans are consuming a blood pressure medication right now, and the three most commonly prescribed ones in adults over 60 are Amlodipine, Losartan, and Lisinopril. Most people consuming them recognize the name on the bottle. They recognize the dose. They recognize they must consume it every day. What most of them do not realize is that these three medications operate in completely different ways inside the body, and that the symptoms they have been quietly enduring, dismissing, or stressing about in silence may have a very particular and very correctable explanation that nobody ever bothered to provide them. That is not a minor gap. That is the kind of gap where real damage develops. I specialize in cardiovascular health and aging, and the pattern I continuously observe in adults over 60 is this. People who are doing everything correctly, consuming their pills faithfully, attending their appointments, maintaining a log, still feeling ambushed by their own bodies because they were handed a prescription and not a complete picture. That shifts today. There are 11 things about Amlodipine, Losartan, and Lisinopril that most seniors were never completely informed of. And by the time we arrive at number 1, you are going to comprehend not just what these medications do, but how to interpret what your body is communicating when something shifts. Because that ability, interpreting the signal before it escalates to a crisis, is the difference between a manageable side effect and an emergency nobody anticipated. Let's begin with the foundation everything else depends on. Number 11. Most people presume that because Amlodipine, Losartan, and Lisinopril are all prescribed for high blood pressure, they are fundamentally the same drug with different names. That presumption is one of the most silently dangerous things a person on blood pressure medication can hold. Amlodipine is a calcium channel blocker. Losartan is an ARB, an angiotensin receptor blocker. Lisinopril is an ACE inhibitor. They all reduce blood pressure, yes, but they arrive there through completely different pathways inside the body. Different mechanisms produce different side effect profiles. Different side effect profiles produce different warning signs, and if you do not recognize which class your drug belongs to, you will misinterpret the signals your body delivers you. Amlodipine relaxes blood vessels by preventing calcium from entering the vessel walls. Lisinopril blocks an enzyme that causes blood vessels to constrict. Losartan blocks the receptor that enzyme's end product attempts to bind to. Same destination, 3 completely different routes. What occurs along each route is what this entire video explores. Margaret was 68, recently retired, and had been on Amlodipine for 4 months when she began noticing her ankles were swollen by evening. She assumed it was heart failure. Her daughter rushed her to urgent care. When I talked with Margaret later, she explained, "If someone had simply mentioned this pill sometimes does that to your legs, I would not have spent 3 weeks terrified I was dying." That one sentence, that one piece of context she was never provided, would have changed everything. The name on your bottle reveals the class. The class reveals the pattern. Once you recognize the pattern, you stop being blindsided by your own body. Number 10. And this is the one that drives more seniors to urgent care than nearly anything else on this list. Not because it is the most hazardous, but because it is the most misidentified. Amlodipine can produce ankle and leg swelling. Not because something is failing with your heart, not because your kidneys are deteriorating, not because you consumed too much salt, but because of the particular way this drug relaxes blood vessels. The small arteries relax more than the veins do. Blood travels into the lower legs more easily than it travels back out. Fluid seeps into the surrounding tissue. By evening, socks leave indentations. Shoes feel snug. Legs feel heavy. Howard was 74, a retired mail carrier from Akron, Ohio. He had spent decades on his feet and felt genuine pride in his mobility. 3 weeks after beginning Amlodipine, he observed his ankles were swollen every afternoon. He mentioned nothing to his doctor for 6 weeks because he did not want to appear as complaining. He began skipping doses on days he had activities, a grandkids' baseball game, a church picnic, because he was embarrassed by how his legs appeared in shorts. That is how a manageable side effect quietly transformed into uncontrolled blood pressure. When Howard eventually came in, he shared, "I simply didn't realize it was the pill. I assumed that was just me now." That is not merely Howard's story. That is the story of thousands of people on amlodipine who are silently skipping doses for a reason nobody ever identified for them. The swelling may not indicate the drug is wrong permanently. It absolutely indicates the conversation needs to occur. Number 9, and this one lurks in plain sight for months before most people draw the connection. Lisinopril can produce a dry, persistent, unrelenting cough. What makes this especially deceptive is that the cough does not always begin immediately. Sometimes it surfaces within days. Sometimes it requires weeks. And sometimes this is the element that confuses people. It emerges months after beginning the medication. By then, patients have blamed allergy season, the new air freshener, lingering cold, their neighbor's cat, acid reflux, or simply getting older. They purchase lozenges. They switch detergents. They sleep propped up on an extra pillow and still awaken coughing. Evelyn was 71, a retired schoolteacher from Baton Rouge. 5 months after beginning Lisinopril, she developed a tickle in her throat that refused to subside. The cough roused her at 2 o'clock in the morning. She stopped hosting friends for dinner because she kept excusing herself from the table. When I requested her to walk me through precisely when it began relative to her medication, she went completely still. "Nobody informed me it could begin that late," she said. "I assumed late meant 2 weeks." Once the connection was established, everything else fell into place. But here's the thing I require you to hear clearly. A dry cough on Lisinopril is typically annoying, not dangerous. The symptom that requires immediate action is something else entirely, and swelling of the lips, the tongue, the face, or the throat, especially if swallowing or breathing becomes difficult. That is called angioedema. That is not a call the office Monday situation. That is emergency care immediately. ACE inhibitors like Lisinopril can in rare instances produce angioedema, and it can escalate very rapidly. A cough, frustrating. Throat swelling, act now. Recognize the difference. Number 8, and this one catches people every single time because it hides in the healthiest aisle of the grocery store. If you are consuming Losartan or Lisinopril, potassium is not a neutral subject. Both of these medications can elevate potassium levels in the blood, and hyperkalemia affects the electrical rhythm of your heart in ways that do not always announce themselves loudly. Weakness, muscle cramps, tingling in the hands or feet, occasional skipped beats, sometimes barely any symptoms at all until the labs return and everyone moves quickly. Here is where it becomes hazardous. Most people here watch your potassium and assume, fine, I don't consume supplements. But potassium is not exclusively in supplement bottles. It is in salt substitutes, the variety marketed specifically to heart-conscious seniors. It is in electrolyte powders. It is in certain meal replacements. It is lurking in products people grab specifically because they are attempting to be healthy. Dennis was 77, a retired electrician from Phoenix. After his doctor cautioned him to monitor his sodium, Dennis switched to a salt substitute he discovered at the health food store and applied it to everything. Eggs, chicken, vegetables, you name it. What nobody had connected for him was that his Losartan was already pushing his potassium higher, and now he was seasoning every meal with additional amounts of it. He began feeling weak. He detected a fluttering in his chest that appeared and disappeared. When his labs returned, his potassium was elevated enough to require immediate intervention. Dennis looked at me and stated, "I was doing everything I believed I was supposed to do." He was correct. He was following every piece of guidance he had been given. The piece nobody provided him was the one that mattered most. If you are on Losartan or Lisinopril, before you grab a salt substitute or any heart-healthy seasoning blend, that is a discussion worth having with your doctor first. Now, here is something most people never hear expressed plainly, and it reframes everything discussed so far about these 3 medications. None of the side effects addressed in this video, not the swelling, not the cough, not the potassium shift, occurs because something went wrong with your prescription. They occur because these medications are performing exactly what they were engineered to do. The issue is not the drug functioning. The issue is the drug functioning without the person comprehending what functioning looks like inside a real body. That is the gap, and that gap is what converts a manageable side effect into a fear spiral, a missed dose, or an emergency room visit. Every item remaining on this list exists in that same gap. Stay with me. Number 7, and this one triggers more unnecessary panic than nearly anything else on this list, because it appears in a lab result before anyone has had an opportunity to clarify it. Losartan and Lisinopril are not solely blood pressure drugs. In the appropriate person, they safeguard the kidneys and the heart over the long term. But when you initially begin them, or when the dose increases, your doctor may order blood work and discover a small change in kidney function, a rise in creatinine, a dip in eGFR. For a senior who reviews their patient portal before the doctor has called, that number resembles damage. It resembles proof the medication is harming them. Sometimes it is a concern. But sometimes, and this is the essential nuance, a small early shift is an expected mechanical change, not an indication of injury. These drugs alter the pressure dynamics inside the kidney's filtering system. A mild, stable change under medical supervision is a very different thing from a dangerous and worsening decline. Sandra was 69, a retired nurse from Minneapolis who had early-stage kidney disease and high blood pressure. Her doctor initiated Lisinopril specifically because it could safeguard her kidneys long term. 2 weeks later, she noticed a changed creatinine number in her portal at 10 o'clock at night. She nearly discontinued the medication that same evening. When we talked, she shared, "I understand what creatinine means. I simply didn't realize that a small change could sometimes be acceptable. Even someone with medical training required the full context. Imagine everyone who doesn't possess it. If your labs shift after beginning these medications, do not guess. Do not discontinue. Call. The number that shifted is a data point, not a verdict." Number 6, this one does not receive nearly enough attention, and it catches people completely off guard because it occurs during the moments they are already feeling their worst. If you are on Losartan or Lisinopril and you contract a stomach bug, a bad episode of vomiting or diarrhea, a fever that has you perspiring through the night, the medication that was safeguarding you yesterday may behave very differently in your body today. Dehydration reduces blood volume. Reduced blood volume alters how intensely the drug hits. Blood pressure can plummet too far. The kidneys, already managing the medication's effects, come under sudden additional strain. Dizziness, weakness, fainting. Acute kidney strain faster than most people believe is possible. Gerald was 79, a retired shop foreman from Cleveland. He contracted a stomach virus on a Tuesday. Nothing dramatic, just couldn't retain much down. He consumed his Losartan Wednesday morning the same as always because he was proud of never missing a pill. That afternoon, he rose from his recliner and the room tilted. He clutched the door frame. His wife dialed 911. In the ER, his blood pressure had dropped significantly and his kidney markers were elevated. Gerald was not negligent. He was devoted. What he required and never received was a sick day plan. He shared from his hospital bed, "Nobody ever mentioned the pill changes when your body changes." That sentence should be printed on every prescription bag. When illness changes your hydration, it changes the rules. That is not a reason to discontinue your medication on your own. It is a reason to contact your doctor before deciding what to do. Now, I want to pause here for a moment because I hear this from seniors regularly, and I suspect some of you watching right now have experienced precisely this. When you first detected something was off, the swelling, the cough, the dizziness, the fatigue, what did you convince yourself it was? Did you attribute it to age, to stress, to something you consumed? And how long did it take before you linked it to the medication? If you're willing to share that in the comments, please do. Someone watching this right now is in the middle of that exact confusion and hasn't found the words for it yet. Your experience could be the thing that helps them identify it. Number 5, and this one resides in millions of medicine cabinets right beside the blood pressure pill, and almost nobody flags it as a concern. If you are consuming Lisinopril or Losartan, especially if you also consume a diuretic, a water pill, regular use of over-the-counter anti-inflammatory pain relievers like ibuprofen or naproxen can create a combination that places real strain on the kidneys. Individually, each component seems innocent. A blood pressure pill, a water pill, something for the knee on a rough day. But together, particularly when you are not adequately hydrated, they can diminish blood flow to the kidneys and increase the risk of kidney injury in ways that appear quietly in labs long before there is an obvious symptom. The reason most people never link this is straightforward. They do not consider ibuprofen as a medication. It came from a drugstore shelf, not a pharmacy counter. It does not seem like something that needs to be reported at the doctor's office. Beverly was 72, a retired bookkeeper from Nashville. She consumed lisinopril for blood pressure, a water pill for mild leg swelling, and ibuprofen 4 or 5 times a week for arthritis in both hands. She was meticulous about her prescriptions and completely oblivious that what she purchased herself at the grocery store was interacting with both of them. Her labs gradually deteriorated. Her blood pressure became harder to manage. When the complete picture came together, she shared, "I never considered it as mixing medications. I simply considered it as something for pain." Once we identified safer alternatives for her arthritis and tightened monitoring, things stabilized. But Beverly had been unknowingly working against her own treatment for months. If you consume Losartan or Lisinopril, over-the-counter pain relievers are not a trivial subject. They deserve a genuine conversation. Before arriving at number 4, here is something that transforms how you interpret everything still ahead. Every item so far, the swelling, the cough, the potassium, the kidney shifts, the dehydration, the pain reliever interaction, none of them required the medication to be incorrect for the patient. In most of these situations, the drug was performing exactly the correct job. The danger originated from a piece of information that was never handed over, which means the remaining items are not merely about side effects. They are about the particular moments where possessing the right information is the difference between remaining safe and sliding into a crisis that was entirely preventable. Number 4, and this is the one that ends up in the emergency room as a fall, not a cardiac event, not a kidney concern, a fall. All 3 of these medications, particularly when initiating them or increasing the dose, can produce dizziness. That woozy few seconds when you stand up too rapidly, the slight unsteadiness in the bathroom at night. People dismiss it. I merely got up too fast. Perhaps. But in adults over 60, a few seconds of dizziness can become a fractured wrist, a broken hip, a head injury. And residing alone in the middle of the night, the margin for error is not generous. What most patients are not informed is that dizziness in this context is not random. It often occurs because the medication is performing its job a bit too aggressively for the body's current state. Current hydration, current combination of other medications, current time of day relative to the dose. Raymond was 81 and resided alone in a ranch house outside Tucson. 2 days after his Amlodipine dose was increased, he rose at 3 o'clock in the morning to use the bathroom. The room tilted. He clutched the towel bar, which held and did not fall. He shared the next morning, "I wasn't frightened until after. Then I couldn't stop imagining what would have occurred if I'd clutched air instead of that bar." Nobody had informed Raymond to sit on the edge of the bed for 30 seconds before standing. Nobody had informed him that rising slowly at night matters especially in the first week after a dose change. That 30-second pause costs nothing. Raymond now refers to it as the most important 30 seconds of his day. Mild dizziness that resolves in a few days is often the body adjusting. Dizziness that continues, intensifies, or results in near fainting is a symptom that belongs in a phone call to your doctor that day. Number 3, And this one does not originate from the medication at all. It originates from the way people monitor their own numbers. Blood pressure fluctuates. It shifts with sleep, pain, anxiety, caffeine, conversation, posture, meals, and the stress of measuring it. A single reading is a snapshot. What matters is a pattern across days and weeks, not what the monitor displayed after you hurried in from outside, not the number you measured 3 times in a row because you did not accept the first 2. When people conclude one high reading means their medication has failed, they make impulsive decisions. Extra doses, skipped doses, demands for a medication change based on a Tuesday morning panic measurement, and effective medication plus faulty interpretation produces bad outcomes with reliable consistency. Patricia was 66, a retired librarian from Portland. She monitored her blood pressure whenever she felt anxious, which because she was anxious about her blood pressure was often. High reading, measure again. Still high, measure a third time. She filled 2 pages of a notebook with numbers that fluctuated wildly and persuaded herself her Lisinopril had stopped functioning. When we slowed the process down, standardized the time of day, had her rest quietly for 5 minutes before measuring, and examined the full 2-week trend, the medication was functioning reasonably well. "I was frightening myself with my own data," she shared. That sentence is precisely right. Consistency in measurement is not a minor detail. It is the difference between useful information and a source of daily dread. Number 2, timing and consistency. And this is where devoted patients silently cause themselves real harm without understanding it. These 3 medications function by building and maintaining a steady effect in the body. They are not rescue pills for a spike you detected at noon. They are long-game medications that depend on being consumed at roughly the same time each day.